Hello, I'm Manoj Karmakar. Welcome to ISSPS TV. Through this channel, we hope to bring you quality education in regional anesthesia. If you like any of our videos, then do remember to click the like and share button. If you are new to our channel, do remember to subscribe so that you can get regular notification of any future uploads.
Thank you, Manoj, for all this very fruitful information on your very unique event. And I'm more than happy to have joined, and I hope we will learn a lot all together during this series. So, my topic is relevant anatomy, of course, also functional for central neuraxial blocks, plain and or regional in the lumbar area. If you see this guy, it seems easy. If we come from outside, inside to the vertebral canal at the end. First of all, palpation, and let me point out that position and status of the thoracic spine is equally important to understand position and or alterations of the lumbar spine. And of course, we have to do dynamical investigation and or inspection. So it's very important and very notable that any change of posture of the human body will change the course and topography of the spine as a whole, and especially of the lumbar spine. And even in young individuals, as you see here, you may have scoliosis, and that makes it more difficult, but definitely you will not have any problems in palpating spinous processes, etc. But we have worse cases, that means severe scoliosis, etc. I'm not talking about pathology, but show you 2 or 3 slides as a representative to compare with the so-called normal. And of course, we all know obesity is a problem. And as you see, it's easy to palpate, for example, in the thoracic spine processes, but it may be very, very difficult to find landmarks, osseous landmarks in such individuals. And of course, ultrasound helps you a lot because your orientation is almost always possible or even excellent. So we start with an image where on the right-hand side, you see removed erector spinae muscles. On the left, everything is intact, including the thoracolumbar fascia. And this is an example where I probably go to the spinal canal, and we will come from outside skin and go and end up in the intrathecal space. A cross section shows you if you go through the midline, you have to cross a lot of ligamentous stuff. And if you come from paramedian in an oblique way to go to the epidural space, it's completely different. So skin is the same, but then instead of ligaments, you have the thoracolumbar fascia and then the whole mass of erector spinae muscles. We will show everything in detail in the sequel. So I start with osseous, important osseous anatomy, and we have to talk about the interspinous, interlaminar space, of course, the spinal canal boundaries, and what I call the interarticular notch. It's not in the official terminology, but you will see it is of utmost importance. If you look on a spine from posterior in black, you see marked the spinous processes, but keep in mind, they're not one above the other in a straight line always, even in very normal vertebral columns. As seen here, number 4 is displaced, and this is important, palpation, sonography, etc. So if you palpate spinous processes, do not expect them one above or below the other. That's just normal anatomy. And if we talk about the interspinous space, it's clear in lordosis, as seen left-hand side. They are rather narrow, especially in the upper part. And you can get rid of lordosis and open those interspinous spaces easily in healthy persons, not always in pathological conditions. But there are other ways, as you will see. So position, posture is absolutely important. And keep in mind also, there are variations. That's not pathology. where you have drop-like extensions, caudal extensions of the spinous processes. And this makes the height and accessibility through those interspinal spaces to the aim, which is the vertebral canal, more difficult. And a huge number of variations exist in the so-called lumbosacral transitional zone. And you need a lot of experience to get them right, but again, sonography will help you in clarifying this. And we're also talking about the interlaminar space. And this interlaminar space is best seen as in the middle part of my presentation in a posterolateral view. And this is exactly what you do if you go with your sagittal ultrasound orientation from outwards inwards. And keep in mind also a lot of not variations, but starting pathological conditions may occur, especially in the transition zone to the thorax, because as indicated in our red arrow, you have a lot of ossifications, and not so rarely you will have them in the ligamentum, flavum, that we have to discuss in detail in a sequel. And now let me introduce the so-called interarticular notch. And you see a difference between the lumbar spine, bottom right, the thoracic spine that we will discuss in 2 weeks, and we will not, or I will not discuss that, but you will discuss that in the sequel of the series, the webinar, the cervical interarticular notch. All of them are different. And this is a key to understand how wide are the windows that you get, for example, to use ultrasonography. And the thoracolumbar transition zone is important. If you see TH11, 12, and this would be lumbar vertebra 1, you see the opening, that means the access to our vertebral canal is pretty okay. It's very much comparable to the lumbar spine per se. So that's a good thing to get the knowledge about this. I don't go into details because it's not for our access directly, but just to remind you that the transverse processes of TH11 and 12 are completely different to 10, 9, and above. So it's clear that the vertebra try to get similarities to the lumbar spine. And now you all know the phenomenon of the kissing spine, and you see the spinous processes touch each other, and there's no access in the median to the vertebral canal. And because there's also alteration of the facet joints, you see an inferior articular process almost pushing to the neck of this so-called Scotty dog. That means the access through the interlaminar space is very narrow. But fortunately, you will find, especially with sonography, there are windows to be accessed. So use it in combination with your clinical picture. And as said, this is no longer lumbar, this is TH12, and very common. You have ossification of the, we call it yellow or ligamentum flavum. And the more you go to the thoracic area, the higher the number of ossifications. That's a phenomenon. Ossification of the ligamentum flavum in the lumbar area is less frequent than in the thoracic. We will discuss that in 2 weeks. A typical L2 vertebra, to understand what's the boundaries as far as I'm from the osseous side, you see the vertebral arch, the pedicle, and the lamina that fuses from both sides to the spinous process. And of course, the posterior aspect of a vertebral body. But I may remind you that in the lower part of a posterior aspect of a lumbar vertebrae, there is no osseous boundary, because if you put two together, you have your big intervertebral foramen. And as you will see, the boundaries of this is also done by one important structure that we have to discuss. It's the ligamentum flavum. Again, I indicated this because this is clinically important. That's the so-called interarticular portion of lumbar vertebra. That's important because there's almost no sponges material inside, and that is prone to fracture. And now what's the difference? L1 to L4 look pretty much as my typical example from L2, but L5 is so different. And that makes it that our vertebral canal is from the shape completely different. And if you have a picture of a cross section of the sacral canal in mind, it resembles that. It gets narrower, and from this form and shape got almost triangular. And the articular processes are very close to the osseous borders of the spinal canal, a little bit in contrast to L1 to L3 and 4. So after having seen the osseous part, we go to the ligamentous part. It's supraspinous, intraspinous, and of course the ligamentum flavum. Supraspinous, you have seen this picture, but now from a different aspect. You see the supraspinous ligament covers those spinal processes. And again, as I said, this is 1, 2, and so forth. They are not exactly one above the other. Here, yes, 5, 3, 4. So keep that in mind. And the thoracolumbar fascia. We cannot talk about the supraspinous ligament without mentioning the thoracolumbar fascia. And as you see in the detail of this cross section, that's a functional unit. And in a few minutes, you will see other ligaments do the same. Building functional units, not isolated structures. The next is the interspinous. Of course, if you see from posterior, not so well seen, you will see that in a second. And the ligamentum flavum that is removed here where the needle is inserted to show in the deep area, the dural sac that will be the last part of my presentation. And in this schematic illustration, this is a real bone, and this is what I did to illustrate the important things. That is the massive interspinous ligament. It's so strong, and it starts here. That means it produces artifacts in ultrasound almost as bad as osseous structures, especially if there are alterations to this ligament. And the ligamentum flavum that spans between true laminae and more, as you will see, because attachments are not so well known to everybody. And here in this example, you see a gap between left and right ligamentum flavum. This is not always the case. Whatever is the case, the gap is always closed by the interspinous ligament. And if you do a cross section, strictly lateral to the median, that means a few millimeters, you get this incredibly beautiful image where you see vertebral bodies. This is the vertebral canal. Everything is removed to show the yellow or ligament or ligamentum flavum. And now keep in mind that from posterior you have the interspinous ligament between spinous processes, a very thick and massive ligament of collagen. In contrast, the ligamentum flavum is elastic material, and it comes from the upper border of a lamina of the lower vertebrae. And this is now important for ultrasound. It does not attach to the next higher in the same area. It attaches to the inner side of the lamina of the next higher vertebra. That is important. That means almost half of the ligamentum flavum that you see in ultrasound is the lower part, and the more cranial part is not seen at all. But it is an important landmark. Same seen here in the lower segment. It comes from the rim of the lower lamina and goes to the, again, inner side of the next higher lamina. That is important. And see how massive this ligament is. And this is why I can easily see it with ultrasound. And this is also not so well understood. A lot of people think this white lines represent the ligamentum flavum. If you have heard what I said, that's not possible, because this attaches to the outer side of the lamina. And as seen in the cross section just a few seconds before, it goes to the inner side. That means this part of the ligament is not visible with ultrasound. Again, it is a good landmark to go to the epidural spaces, you will see. Now, details on the ligamentum flavum. This is a view from inner side outside. That means we have removed body, just the vertebral arch. This is the pedicle. That's the transverse processes. And you clearly see, I mark it here, that the ligamentum flavum comes from the upper rim of the lower lamina and goes again to the inner side of the next higher lamina. And this is not so well known. It extends far laterally and also attaches to the pedicle of the next vertebra, not only the lamina. This is why it makes border of the intervertebral foramen. And as you see, there's a little gap, there's a bigger gap here, and these are not so uncommon. And generally speaking, the more caudal you go in the lumbar spine, the less frequent will these gaps be. These are a few morphological examples. You see the ligamentum flavum, gap more caudally, a gap throughout, and a very broad gap. That may have a tremendous influence on your approach. If you go to the median, have big gaps, and you don't really feel a loss of resistance by going there, quite in contrast to the paramedian approach. And now you have seen this picture. Now in detail, this, what I marked here, is the ligamentum flavum. That's the last one between S1 and L5. And you see how massive this is. Of course, it's understandable because functionally speaking, it's the most loaded part between sacrum and L5. But there's a direct continuation and attachment to the interspinous ligament that also covers part of the lateral parts of the spinous process, and the supraspinous ligament. And as I've pointed out, it is a functional unit with the thoracolumbar fascia, very thick aponeurotic stuff in the lumbar area. And now I think you can easily understand that all of these ligaments make a functional unit. You cannot have changes of the one without influence, functionally speaking, to the other. And here is the epidural space in this part, in the lowermost part of the lumbar spine, very, very little and narrow. And this speaks for itself. That's a beautiful image ultrasound between S1 and L5, and you see this very, very thick structure. And this is the ligamentum flavum, the last one between L5 and S1. Why don't you see anything in the deep area? This is because of the steep inclination of that ligament in that area. If you want to see the ligament clearly, you cannot always see the other parts of the epidural and intrathecal parts, in contrast to the more upper part of the lumbar spine. And this is a typical example of a lumbar area cross section, and you see the epidural space, and importantly, it continues laterally to the paravertebral space through the so-called intervertebral foramen. I myself always call it intervertebral canal, because especially if you go more caudal, it's not a foramen, it's a real true canal. By the way, this is an illustration where we filled it with blue ink, and you see it continues outside to the lateral area. That means also to the paravertebral area. This is part of the cauda equina, and typically the more caudal you go, the more posterior will those filaments of the cauda equina be located. As an overview, you clearly see this is the whole lumbar spine, this is sacrum, and the epidural space gets narrower and gets narrower, and in a minute I will also explain the position of the spinal cord. And importantly, you see that it's filled with fat, and blue or dark dots, that's veins. That means that's the posterior part of the venous plexus in the epidural area. And again, you may easily visualize this epidural space by respecting this is the ligamentum flavum and this is the dorsal dura in the upper part of the lumbar spine. And as seen here, you see a lot. And this will be the last picture I explain in detail. And in 2 weeks, I will also go detailed into the anatomy of the thoracic spine, just to remind you that in the thoracic area, the vertebral epidural venous plexus is massive. And in the lumbar part, it's far less prominent. Of course, you beautifully see also here the combination of epidural through foramen through the paravertebral area. And as I said, not everything is beautiful. This is obviously an aortic spine. You see a huge pathology here in the distal area, but you also see bleeding and subarachnoidal bleeding. But I want to point out also in the lumbar area, you clearly see veins from the plexus, and the subdural or epidural, fat and connective tissue is seen in combination with the intervertebral canal. This would be a ganglion, one of the lumbar ganglia, and you clearly see asymmetry. So this spine is typically not in order or in normal shape. You see the transverse process, we call it coastal process, and nothing like this here. There's asymmetry. But still, you have the huge, massive ligamentum flavum, which in this case is closed. There's no gap. And that directly could lead you to the epidural space. Again, despite pathology. And this is another example, same individual, lower segment, last one, and you see the ligamentum flavum, and there's massive bleeding inside of the intrathecal area. And in contrast to the ligament, you have lamina here. Again, massive asymmetry, and you see the changes of the whole bones. That's not normal bone. And you also see fatty degeneration of the muscles if you go, for example, through the erector spiny part, but the lumbar, the superficial layer of the thoracolumbar fascia is beautifully seen still. A little few words on the neonate and the first 2 or 3 years of development in the human. You see, open the epidural space, and I tried to simulate with this little kind of fluid that fat, and that is functionally important, is fluid under normal temperature. That means in the living, it's not as you see it in the cadaver, it's fluid. That means it's an ideal protection of the dural sac, and the dural sac itself with its filled spinal cord fluid is the next protection for the spinal cord itself. And as seen here, I did it in a magnification. It's a wonderful preparation where you also see it's not only fat, it's also connective tissue strands. But the difference to the adults is that the epidural space in the neonates and first 3 years is tremendously bigger, and dimensions are greater than in the adults. And this is a beautiful example where you see development has not stopped. That's a lumbar vertebra, and you see the epidural space, and this is fat and a lot of connective tissue strands. And here's the dural sac that we talk about now. The dural sac in the adult, late 3 here, and it ends at S2 level in most cases. Be aware of the fact that there's tremendous variability in both kids, neonates, and adults, but that's the more or less the room. And you see protection from dorsal, it's osseous, then you have the epidural space, we remove the fat, you have the dural sac, and it ends here at S2 level. Importantly, functionally speaking, the dura has a clear architecture that was described as early as in 1929 by Titus von Lantz, and it exactly follows the needs, the mechanical needs that we find in the individual. And only in the part near the median, you will have strict longitudinal collagen fibers. Everything else is a beautiful architecture that resembles function. And you see the dural cuffs extending laterally. Also very, very different in different levels and very different in individuals. The dural sac in neonates, it ends as S4, and this is important, as you know, if you do a caudal. And again, variability is the law of life. It may differ over 1 or even 2 segments. And the spinal cord ends at L4 in the neonate, and the subarachnoidal space, that means the intrathecal space, is of course as long as is the dural sac. And as I said, the spinal cord ends at L4 in neonates in most cases. And last but not least, let's go intrathecal. You see a beautiful cross section where you see it's a higher level, it's the thoracolumbar junction. You see the spinal cord with its covering, that's the pia. And between dura and pia, there's a remarkable structure, that's the denticulate ligament. You see that also in cross sections. And these are the rootlets. and it is between anterior or ventral and posterior rootlets of a spinal nerve. And important, you see that in magnification, very beautiful. It's a soul-like ligament, and that's collagenous stuff that combines pia mater with dura mater, and that gives a separation on one hand, and on the other hand, it is mechanically so important because it keeps the vertebral, the spinal cord in position. So you can say the spinal cord is like in a swimming pool, and in this is protected by fluid. And importantly, you all know that the anastomosis is longitudinal to supply the spinal cord, but keep in mind and have a look at one of those filaments. Every little rootlet has its own vascular supply. That is important, functionally speaking. And you also see there's more than just the denticulate ligament, there's also separations. And the following speaker, I think, or the following two speakers will point that out in detail. So there's more than just one ligament, intrathecal. And to close up, we have come from outside and have ended up in the vertebral canal and in the intrathecal area or the dural sac. Let's do it the other way around. Not so important for a posterior approach, but even visible is the posterior longitudinal ligament, a very narrow anterior epidural space. The next layer would be the ventral dura. Then you see the intrathecal area with the cauda equina. You see the posterior dura. You see the epidural space. And last but not least, our key landmark ligament, which is the ligamentum flavum, as mentioned. And we started osseous. Of course, you see the acoustic shadowing created by two laminae, one above the other. And by doing this approach, you have beautiful access to all of these parts, epidural or intrathecal, etc. But keep in mind the anatomy. Keep in mind that anatomy is different from L1 to sacral canal, and you can appreciate that by using ultrasound. That was it. I thank you for your attention. And remember, if you do your job, do it seriously. Really. But don't take yourself too seriously. And I hope you will have fun in the next parts of that webinar.